I'm Shonni Silverberg, and today we're going to gallop through about 4 or 5 talks condensed into one on primary hyperparathyroidism. I have no disclosures. But I'm not really going to talk a great deal about some of the very fundamental issues because you guys are grown-ups and know many of these things. I know well that primary hyperparathyroidism in about 80% of cases is caused by a single adenoma, and foregland hyperplasia is a distant second in terms of etiology. I'm also not going to talk about inherited primary hyperparathyroidism, and this is just a time issue in order to get to all the different facets of the clinical presentation of the disorder. But suffice it to say, there are many different familial syndromes associated with. Does this not work? No? Never mind. So the vast majority are sporadic. There are a small percentage of cases that are associated with radiation or with lithium use, and inherited primary hyperparathyroidism is found in 10 to 15% of cases, although as we increase our understanding of the genetics of many things and primary hyperparathyroidism as well, that number is likely to rise. So when I was in medical school, I learned about this disorder with the descriptor of Fuller-Albright, a disease of bones, stones, and psychic groans. And in particular, it was characterized, at least historically, by osteitis fibrosa cystica, a particular bone disease that was seen that had resorption of the distal phalanges and the clavicles, was associated with salt and pepper skull and with brown tumors. These pictures, which again I can't show you with a pointer, are a curiosity today for the most part.
You can point on the screen.
Point on the screen? Okay, thank you.
It won't get in my way.
And instead, the disorder is really characterized by not very much in most cases. Indeed, about 80% of cases have no clear clinical symptoms that are associated or referable to the disease. About 20% of cases are associated with nephrolithiasis, which is the most common clinical presentation. Am I in your way?
No.
Okay. And as you can see on this slide, the clinical presentation has evolved significantly with a decrease in the incidence of symptoms and an increase in the presentation of asymptomatic disease. When the multi-channel autoanalyzer was first introduced in the 1960s and early 1970s, for the first time, physicians who were interested in their patients' creatinine levels and glucose levels started getting for free and unasked for serum calcium levels as well. And the phenomenon of asymptomatic hypercalcemia, which would lead to a big workup generally because of concerns about malignancy, which is the other main explanation for hypercalcemia, would ultimately lead to the diagnosis of primary hyperparathyroidism. But that was really the first time that somebody would have found this disease in a completely asymptomatic individual. Having said that, the classic target organs are still involved in the disease. Nephrolithiasis, as I mentioned before, is seen in 15 or 20% of patients. Nobody really knows the precise percentage of patients who have nephrocalcinosis, but we were particularly curious in the early 1980s with the recognition of this new phenotype, whether or not the bone was still involved, despite the fact that we no longer saw osteitis fibrosa cystica. And at about the same time, bone densitometry was in its infancy. It was not DEXA at that time. It was single and dual photon absorptiometry. But both DEXA and single and dual photon absorptiometry, which was its parent, were of interest in regards to this particular disease as it was for osteoporosis because of the different amounts of different types of bone at different sites. So the lumbar spine is mainly made up of cancellous or trabecular bone. The distal 1/3 radius is much more cortical in nature, and the hip is somewhat more evenly distributed between cortical and cancellous bone. And most people were interested in osteoporosis, which actually, as you all have heard probably a million times already, mainly is a disease of trabecular bone. And we were interested in the bone density at the forearm because we already knew from previous information on osteitis fibrosa cystica that cortical bone is a main target, and that parathyroid hormone is catabolic in cortical bone. And so we were not surprised to see the diminution that you see in the red bar here of bone density relative to age and gender and matched peers. But we were somewhat surprised, or hadn't really thought through the fact that there was going to be so much preservation of bone density at the more highly trabecular lumbar spine. And this was particularly of interest because over 50% of the patients with primary hyperparathyroidism are postmenopausal women. And when this exact graph is done just in this postmenopausal subset, it looks exactly the same, so that there is much better bone at the spine and much worse bone at the 1/3 radius. This is a histomorphometric a sample. This is just a scanning EM of 2 individuals who are age and gender and menopausal status matched. And as you can see, even with the naked eye, the individuals with primary hyperparathyroidism have markedly thinned cortices relative to the normal sample. And what is harder to see with the naked eye, but I assure you is true, is that the trabecular bone is actually increased, both in terms of its volume and its connectivity. So the question that would logically come next is whether or not the reductions in bone density seen at the 1/3 radius are associated with an increased risk of fractures, and particularly cortical fractures. And what is true, but we didn't know for sure, is that the association between bone density and fracture risk that holds in postmenopausal women without primary hyperparathyroidism, we have really no idea and no data to suggest that primary hyperparathyroidism is the exact same, nor do we have any idea whether or not FRAX is a tool that is particularly useful in primary hyperparathyroidism. I think at this point most people put, if someone has primary hyperparathyroidism, they say there's a secondary cause, but we don't actually know how primary hyperparathyroidism plays into the FRAX calculation. What we thought at this point was that based on the information that we had from DEXA and from histomorphometric calculations, was that cortical bone is probably at increased risk for fracture. And we really didn't know what the risk was in trabecular bone, and we actually thought that maybe there would be a lower risk based on the fact that we did see preservation of the bone density. But the clinical studies that were available for a while have suggested that the risk at sites that are highly cancellous are increased. And this slide shows an increase in any fracture, but also, and actually particularly, an increase in vertebral fractures in primary hyperparathyroidism. And so that would have been a site that we might have expected would have had decreased fracture incidence, but that's not the case. So there was no site at which fracture incidence was not increased. The proximal femur, as you can see, the relative risk is right at 1, but other than that, everything is statistically significantly increased. And in fact, in other studies as well, vertebral fractures are significantly higher in primary hyperparathyroidism relative to controls. So the question came up how to explain the discrepancy. Initially, we thought it might just be that people who had primary hyperparathyroidism were surveilled more closely than the general population, and therefore subclinical vertebral fractures were being picked up. But we no longer think that that is the case. And this is a slide that you have probably already seen a bunch of times by this time in your sojourn with us, but it has become increasingly clear over the years that bone density, while it is the most important contributor to bone strength, it is not by any means the only contributor to bone strength. And obviously bone microarchitecture, the matrix composition, mineralization, and bone size and turnover are also important determinants of whether or not an individual fractures. And similarly, I am correct that you've seen the HRP-QCT in other lectures, or is this the first time? Am I?
We've heard it exists.
Okay, so here we go, and what you can see, and what was very attractive for us in terms of thinking about primary hyperparathyroidism, is that the high-resolution peripheral QCT is able to separate the cortical and the trabecular elements, and so we again anticipated that the cortical elements would be decreased and the cortical microarchitecture might be worsened. We were not sure what we would find in the trabecular microarchitecture, although based on DEXA measurements, we thought that it might be improved or at least preserved. So this is a little bit more about the technology, which I think you already know, and also to make the point, which in case no one has already made it with you, that these are HRP-QCT pictures of two individuals with identical bone density on DEXA. And you can see that the pictures that that are here show very different microarchitecture, with the individual on the left having preserved cortices and almost nothing in terms of their trabeculae, and the individual on the right having very ratty and wholly, not in a religious sense, cortical bone and better trabecular microarchitecture. And what we actually found on assessment of HRP-QCT in people with primary hyperparathyroidism was that in addition to their cortical bone density being impaired, all of their trabecular indices were decreased, at least at the radius, and their strength was also decreased and the failure load as well. At the tibia, it was a little bit more spotty, but certainly trabecular bone density and trabecular volume was similarly decreased. So here is a resolution of the paradox that we were faced with in terms of the discrepancy between bone density and fracture, which are very closely aligned in postmenopausal osteoporosis. It seems that that DEXA is does not have adequate resolution to show the trabecular issues, but similarly, bone biopsy did not predict the increase in fracture or the picture that we found on HRP-QCT. And the one possible explanation for that is that the site that is biopsied, which is the iliac crest, is not weight-bearing and may be of different composition than the sites that are truly of interest. HRP-QCT is great because it provides that window into what is actually going on. But HRP-QCT, as you all know, is not readily available, nor at a $500,000 price tag is it likely to become readily available. So what to do? And so what is needed is something that people in the community, or not even in the community, but at academic medical centers other than the 4 in the US that have HRP-QCT machines, can look into this in an individual patient and get more data. Has anybody presented TBS to you? Has it been discussed? Okay, so then I'm going to gloss over, in interest of time, the technology of the trabecular bone score and go right to what happens in primary hyperparathyroidism. And what we found very interestingly, and you can see this in the bottom left panel, is that although only 14% of individuals studied had osteoporosis by T-score. Fully 1/3 or over a third had actually degraded TBS scores, and if you looked at degraded and partially degraded together, over 70% of individuals with primary hyperparathyroidism did not have normal TBS scores, despite the fact that over half of individuals had normal bone density by T-score. So TBS is a way, we think, that can give some more data and more information in individuals with primary hyperparathyroidism. We also found, actually not we, the Italian group actually reported that TBS was lower in fracture patients with primary hyperparathyroidism than in non-fracture patients. So it does seem to be a pretty good discriminator. And so our conclusion was that DEXA and bone histomorphometry do not explain the prevalence of fractures in primary hyperparathyroidism. HRPQCT does a great job, but it is not widely available, and perhaps TBS is something that can be used in an individual patient to assess their trabecular bone. But clearly, it called for a revision of our original hypothesis, which was that this was going to be a disease of cortical bone, to say that now that both cortical and trabecular compartments of the skeleton are affected in primary hyperparathyroidism, even in the new, less severe and relatively, quote-unquote, asymptomatic disease. Moving to some of the more non-classical manifestations of primary hyperparathyroidism, the cardiovascular manifestations are obviously tremendously important, and particularly because in classical primary hyperparathyroidism, there was a significant increase in mortality, particularly from MI and stroke, with clear coronary, vascular, and myocardial calcifications. And left ventricular hypertrophy that regressed with parathyroidectomy. And it was clear to us that if this were the case, even in a small way in asymptomatic hyperparathyroidism, then really everybody should have surgery. And the data on mild disease in terms of mortality from the US comes entirely from the Mayo Clinic. Where in patients as a whole, there was no decrease in mortality, no increase in mortality, I'm sorry, and actually cardiovascular mortality, if anything, was relatively decreased with a 2.6 relative risk, and as you can see, the confidence intervals go from 0.45 to 0.79. However, it is still the case that in the highest quartile of serum calcium levels pointed to with the red arrow on the graph, there is an increase in mortality. So those with the highest serum calcium levels do persistently have an increase in mortality. There was more recently a study out of Scotland that did show an increase in cardiovascular mortality in patients with primary hyperparathyroidism. They looked at ICD-9 codes and many populations in a localized area. They had a huge mortality rate. So they were following 1,400 people, of whom over 400 died. And it was also not a healthy population, but everything is increased in the primary hyperparathyroid cohort. In addition, not only to fatal and non-fatal cardiovascular disease, but cancer, CVAs, hypertension, renal failure, and psychiatric disease. And it raises the question about whether or not this was a representative sample, because I don't think anyone else in the entire universe has ever described a group of patients with primary hyperparathyroidism with this huge incidence of many, many, many diseases, including renal failure. There are very sparse data on coronary artery disease, particularly in the United States, and as you can see, this is the only study that's available and actually only looks at 20 patients. So these 20 patients were matched with 4 controls for each of them from the MESA study and found no increase in coronary calcification. However, I think that there's tremendous limitations in this study because these were mainly women in their 50s and 60s, and so the pretest likelihood of finding coronary calcifications was extremely low. This comes from our study. We did a longitudinal study pre and post parathyroidectomy, looking at people at baseline and then 1 year and 2 years after parathyroidectomy. And at baseline, what we found was that left ventricular hypertrophy was not increased in either men or women with primary hyperparathyroidism. But we were curious about reversibility, and we actually did not find any significant decrease after parathyroidectomy. But Dr. Marcella Walker, from whom I'm sure you have already heard, and if not, you will hear shortly, did a meta-analysis of available data, and it does show a beneficial effect of parathyroidectomy on left ventricular mass of about between 10 and 15% regression. We also were able to take advantage of a visitor from Japan who was with our cardiac echo team for a period of time, and who was able, through some very sophisticated methods, to actually quantify valvular calcification in the aorta. And so what you see on this lovely photograph is that those yellow surrounded areas are actually punctate areas of calcification in the aortic valve leaflets. And what we found was that although the number of calcifications was not increased in primary hyperpara versus controls, age, gender, menopause status match controls, the area of the calcifications were significantly increased, and the calcification area was not associated with calcium levels or with vitamin D levels, but were in fact positively associated with parathyroid hormone levels. And when we looked at vessel stiffness, which is again a more subclinical measure of cardiovascular function, we found that aortic stiffness was increased relative to controls, and that it too was not associated with serum calcium levels, but was associated with parathyroid hormone levels. And when we looked in the carotid, where we actually measured the stiffness directly, the measurement in the aorta was an indirect one. Stiffness was increased in the carotid as well in association with parathyroid hormone levels. We also found that IMT, or intima media thickness in the carotid, was higher in hyperparathyroidism relative to controls, and that while the incidence of carotid plaque was no different among the patients with primary hyperparathyroidism and age and gender matched controls, once those individuals who had plaque, the plaque was much thicker than it was in people without primary hyperparathyroidism. Unfortunately, following these people up after surgery, there was virtually no improvement after the parathyroidectomy, and so that in and of itself, this is not an indication for parathyroidectomy. So a controversial topic, which should not be controversial, hypertension is often found in patients with primary hyperparathyroidism, and primary care physicians and some cardiologists think that hypertension that's difficult to control should be a reason to send an individual for parathyroidectomy. We know that it is causal in patients with MEN, but the question in terms of the much more frequent sporadic disease is a very different one, and for a long time all we had was observational studies, but the single RCT that was able to approach this was one from Scandinavia. And what you see here is that individuals who are randomized to surgery or observation, and the 2-year follow-up is on the graph. The observation is in the open squares. What you see is that in fact systolic blood pressure and diastolic blood pressure and mean arterial pressure did decline over time, but it declined even more in those people who were observed than in people who underwent parathyroidectomy. So you can see that had only the people who had surgery been assessed, this study would have concluded that it was the surgery that fixed them, when in fact, if you look at these data, what you have to conclude is that being in a study is good for your blood pressure, not that surgery for primary hyperparathyroidism does anything at all. This looks at some other cardiovascular risk factors after parathyroidectomy, again in the same randomized study, and found no improvement in BMI, in lipid metabolism, in inflammatory markers, or markers of endothelial function. So to summarize, mortality is not clearly increased in modern day primary hyperparathyroidism. There's insufficient data to make any comment on coronary artery disease, but what we see is not increased. Left ventricular mass is clearly increased in severe disease, not so in mild disease, but there is some improvement related again to disease severity. Aortic calcification has increased severity when it's present, but doesn't improve with parathyroidectomy. And vascular stiffness is increased in association with PTH levels, again, does not clearly improve with parathyroidectomy. IMT similarly is increased, also doesn't improve. Cardiovascular risk factors also don't improve after parathyroid surgery. Moving on now to neuropsychological manifestations.
Can I just ask real quick? You said in the conclusion that at the end, mortality is not increased, but wasn't it increased in patients with high calcium?
Yes.
Okay.
Yeah. So I don't think, the truth is, the more important question for this part, we're talking about the asymptomatic disease. There's nobody who would just follow someone with a calcium of 12, because the calcium of 12 is an indication for surgery for so many things. The question really is there a cardiovascular indication for surgery in people who have very mild biochemical disease? And that is what the data seem to be showing, at least at this point, that there is not. Neuropsychological manifestations are something that any of you who have taken in care of patients with primary hyperpara know exist. The severe manifestations, muscular and neurological as well as psychiatric, are not seen. However, there's no question that patients complain of increased fatigue. They just tire more easily, more frequently depressed and tired. But I would suggest that many of those symptoms are characteristic of many of the postmenopausal women who have primary hyperparathyroidism, as well as their non-hyperparathyroid counterparts. Again, in this peer study, which we still think is something, talking about a population that's at least very different than we see here, they found a 4-fold increase in psychiatric disease. That is certainly something that we don't see. On the other hand, there is no question that even in our studies, we found an increase in indices of anxiety and depression that decreased after parathyroidectomy. It is important to note that the increase was just a statistically significant difference between the two populations. It did not rise to the level of a diagnosis of depression or a diagnosis of a clinical anxiety disorder, so it was much milder than that. So again, it would not have been picked up in the peer study where they were saying that there was a 400% increase in diagnosed psychiatric disease. But we did see a decrease after parathyroidectomy, which are shown in the white bars. This is another study that looked at depression in comparison to thyroid surgery controls, parathyroidectomy versus the thyroid surgery controls, and found a greater improvement with parathyroidectomy compared with people with primary hyperparathyroidism who were just observed with no intervention, or individuals who underwent thyroid surgery. Again, the RCTs are the gold standard for all of us, and there are 3 different RCTs that looked at quality of life indices, and each individual one used the SF-36, which was very nice of them to use the same vehicle, and each of them showed some improvement. The problem is that if you lived in Detroit and you were in Dr. Rao's study, you had an improvement in social functioning or emotional problems. If you were lived in Italy and were in Dr. Ambergini's trial, you had an improvement in bodily pain, general health, vitality, and mental health. And if you lived in Scandinavia and you were in Dr. Bolerslev's study, you had an improvement in physical function and mental health, but your mental health improvement went away after a year. So if you look at the totality of this, you can't say very much, and you certainly can't say anything to someone who's sitting on the other side of your desk and says, what can I expect after parathyroid surgery? We decided to look at cognitive function because it seemed to be a little bit harder, and not harder as in more difficult, but actually easier to have hard endpoints. And in a study that Dr. Marcella Walker did, started when she was a fellow with me, we found actually that there were specific areas of verbal memory and nonverbal abstraction that were worse in patients with primary hyperparathyroidism and improved to levels that they were no longer distinguishable from controls 6 months after parathyroidectomy. There were, however, no differences in visual concentration or visual memory, auditory attention, or mental manipulation, suggesting that the primary hyperparathyroid process affected specific areas and was not necessarily causing a global decline in cognitive function. So our conclusion is that there are the data suggesting that there's an impairment in quality of life, psychiatric and cognitive function, can be part of mild disease. However, the data on reversibility of these symptoms is not strong enough to suggest that that be the only criteria in a given individual. What I often say to my patient is, a beneficial byproduct of having the surgery and being cured is that you may well find that you're not, you're no longer as tired, or you have more energy, or, the indices of anxiety that you complain of may be less. But I never say, whereas I tell them they can expect a certain change in bone density, I would never do that in this situation. Vitamin D deficiency, a common feature of primary hyperparathyroidism when I started looking at this a long time ago. About fully 85% of patients had 25 hydroxy vitamin Ds under 30. At the time, 9 was the cutoff for vitamin D deficiency, but certainly using current cut points. And we found as well that parathyroid hormone levels were highest in patients with lowest vitamin D level, consistent with a secondary hyperparathyroidism superimposed on their primary hyperparathyroidism. However, when we went back to look at this in the 2010 range, we found that primary vitamin D deficiency is no longer particularly common in New York City in patients with primary hyperparathyroidism. And there was a complete reversal, so that in fact, over 80% of patients, as I mentioned, were below 30 in the initial cohort, and less than half of patients were in that area in the more modern cohort. And what we found when we looked at their data was that the calciums hadn't changed really at all. And the only two things that really changed in a very statistically significant way is that the 25 hydroxy D levels became much higher. We're now in the replete range with a mean level of 37, up from 21. And concomitant with that, the parathyroid hormone levels had fallen from a mean of 121 to a mean of 75. The international guidelines since 2009 have suggested that 25 hydroxy D be measured in all patients with primary hyperparathyroidism, and that patients be repleted if they have levels below 20, although no guidelines are provided for that. This is a repletion trial that used high doses, 50,000 units a week for 4 weeks and then 50,000 units a month, and did find a decrease in parathyroid hormone level. Presumably this top part that went down to the yellow bar level was the secondary hyperparathyroid component And then the parathyroid hormone level did not change anymore, as the vitamin D level did not either. This is another study in RCT using 2,800 international units a day for a year in a population with a placebo comparison, and found an increase from a mean of 20 to a mean of 38, and a decline of PTH of about 20%. No change in serum or urinary calcium levels.
Can I ask you a question? It's true that the PTH declined, but when we see a rise in the vitamin D, we expect also a rise in the calcium level.
Right.
So we can say that there is a kind of relative decline of calcium. I mean, it remains stable.
So it remains stable. What we let's see. What they did not do is a 24-hour urine calcium, because in fact that may be where it went. So we don't that we don't have data on, and that's actually you're totally correct. It's got to go someplace. Now, one other hypothesis would be that it went into the bone. Okay, and the bone density actually increased by 2% in this study. They also, with no change in urinary calcium. So it has to go someplace. So you're right. Since the serum calcium isn't the place it went, in this study it would suggest it's going into bone. So as I mentioned, there are currently no guidelines for repletion. Normocalcemic primary hyperparathyroidism, the subject of the full hour's talk that I tried to give you when I initially got here. So we know that when hypercalcemia is first detected, some of the changes in bone density are already in place. And Dr. Bilazikian and I, along with Dr. Rao and Parfit, hypothesized that there had to be a preclinical stage of the disease when the PTH was elevated, but the serum calcium was not yet increased. But we hypothesized, the pattern that we hypothesized that we would see is that in those patients, that if you followed them over time, they would all become hypercalcemic. We started seeing in the 90s and early 2000s individuals for the first time who were going to bone units or metabolic bone centers, or whose physicians were interested in their bone health, who were getting a bone density, finding a low bone density, and then getting a calcium and PTH at the same time. And some of these patients did in fact have the high PTH with the normal calcium level. The question came up as to whether or not this was a new disease or a different disease. And in fact, at the last two international guidelines, which were published in 2009 and 2014, although the conferences take place a year earlier, leading rise to these confusing date differences. The definition of this new phenotype is characterized by someone whose both total and ionized calciums are always normal, so we don't measure or advocate measuring ionized calciums in people who are hypercalcemic. It's expensive and often poorly done, but certainly in order to make the diagnosis of normocalcemic primary hyperparathyroidism, you have to make sure that it's not just a phenomenon associated with bioavailable calcium levels. The PTH must be elevated, again, to make the diagnosis of hypercalcemic primary hyperparathyroidism. You can have a PTH level that is normal but not suppressed, which would be the appropriate response to hypercalcemia. But obviously, if your calcium is normal and your PTH is normal, you don't have a disease. So in this one, in normocalcemic primary hyperparathyroidism, the PTH levels do need to be elevated. And then secondary causes of primary hyperparathyroidism must be ruled out. Vitamin D deficiency is probably the most common one here. We often pushed people to have their 25D be over 30 before making the diagnosis of normocalcemic primary hyperparathyroidism. And also, if they are on a zero calcium intake, their PTH will remain high as well. Similarly, patients with renal insufficiency, patients who are on medications have marked hypercalciuria, malabsorptive conditions, or other metabolic diseases may have an elevated PTH level, so those all have to be eliminated as well. Many of the patients with normocalcemic primary hyperparathyroidism are diagnosed as part of a workup for osteoporosis or osteopenia. And so the question came up, does normocalcemic primary hyperparathyroidism have worse bones than hypercalcemic? And in all likelihood, that just what we're seeing just reflects a selection bias. They are sent for evaluation in the setting of a workup that was done in a metabolic bone disease center or after the diagnosis of osteoporosis is made. And there have been some studies looking at larger populations that do not suggest that there's worsened bone disease. The data on natural history is limited. The data do suggest that in people who have normocalcemic primary hyperparathyroidism, bone density increases after parathyroid surgery. Some of them respond to bisphosphonates, and some may have no evidence of skeletal involvement. Similarly, there are some who never become hypercalcemic. So there are patients who after a year of observation become hypercalcemic, some after 4, and we have been following some for 12 to 15 years who have been persistently hyperparathyroid and normocalcemic. So where we are today is that rigorous diagnosis is absolutely essential. We are still not sure if it's one disease or several diseases, whether the division is either between symptomatic and asymptomatic, or the non-progressive disease that I just mentioned before versus a disease that is early in the course of hypercalcemic primary hyperparathyroidism. It's clear that there's no single natural history. You can't tell a patient that within 2 years or 4 years they should expect to have a different clinical profile. And clearly, we need more data to figure out more about this disorder. And hopefully some of you in this room will get excited by this and try to collect some of that data for us and the world. So next issue, very briefly and very rapidly. What to do? Surgery remains the only option for cure of primary hyperparathyroidism. I am not going to talk about preoperative localization other than to say the best preoperative localization is whatever is done best at your institution. So we do a combination of a 4D CT with SPECT imaging. Other places do different things. It's what is done well is the right way to go. If preoperative localization is not necessary, if a foregland exploration is contemplated, it is absolutely necessary if a minimally invasive parathyroidectomy is desired. And intraoperative ability to measure parathyroid hormone levels is also necessary if a minimally invasive procedure is planned. With apologies to people who are more interested in the surgery, that could be another whole hour. But what happens with surgery, this is our study, our long-term study. It was an observational study. It looks randomized because there are 60 and 61. It is not randomized. So just that's the caveat. The only long-term data are ours, and it is not from an RCT. But the data are similar to RCT data, which actually only goes out 1 year or 2 years at the most. So people who undergo parathyroidectomy have a normalization of their biochemical indices, and their bone density improves. And it improves a lot, and it improves everywhere. Okay, so at the 1/3 radius, it doesn't improve at the very immediately as it does at the more cancellous sites, the lumbar spine and the femoral neck, but it does improve over time. And the important thing to note here is that this is a group of people who were mainly postmenopausal women, and this is not what a group of postmenopausal women who are not on estrogen and who are being followed over time would look like over a 15-year period. Those who start out with bad bone density at the vertebrae actually even have a more dramatic improvement. And you can see here a 15% improvement at year 1, which goes up close to 20% in those individuals who started out with decreased bone density in the vertebral area. HRPQ-CT similarly improves. This is a before and after picture, and both the cortices and The trabecular indices improve, and what we find also is that strength also improves, as does failure load.
Can I ask? So the reason for the lumbar spine to be better than the radius is just because it's more active, so then?
Yes. Yeah, you mean why does it improve first? Absolutely. So the lumbar spine is the most highly turned over, and so it improves first. The femoral neck improves second. The cortical bone improves, the distal 1/3 radius improves the least. Even it's not just that it improves last, it also improves least. But it does get better, so all sites improve. TBS also improves after parathyroidectomy. The Z-score in this population going from -3 to -1.5 after parathyroidectomy. So basically the improvement is seen no matter what technology you look at. The golden question, of course, is what happens to fracture risk, and we have absolutely no idea. And I would add, we will never know, because what would be required, since fracture is rare in people with primary hyperparathyroidism, it is, at least on the hypothesized level, it would be expected to be even rarer in cured people with hyperparathyroidism, and would require a gigantic multi-center study, and no one seems to have the appetite to fund it. There are plenty of us who have the appetite to do it, but nobody has the appetite to pay for it. So what happens to people who don't get operated on? And the subtext, of course, is it safe to follow people? So in general, people's calcium and PTH levels remain relatively stable. That does not mean in everyone, and so people do need to have these indices followed. Bone density, and this is the same graph that you saw before, dramatically different, obviously no increase, and no decrease in the first 6 to 8 years, so that is very different. On the other hand, these are people who have primary hyperparathyroidism, and most of whom are postmenopausal, and the age at entry is 61, and you certainly would have expected, just with age alone, that there would have been a significant decline, which you actually don't see until you're around 10 years out, okay? And then you start to see the areas with more cortical bone, certainly the radius, and to a lesser extent the femoral neck, do start to decline in a significant fashion. So 37% of patients do have evidence of progressive disease. We used as a measure of progressive disease those people who started to meet a new surgical guideline that existed. And bone density is stable, but does start to decline towards the end of the first decade. So observation is fine for a while, but obviously if someone is younger and is going to live for a long time, or even if they're not, if they are going to live long enough at some point to start having deleterious effects, unlimited observation is probably not a great thing. So the questions that were asked and answered in the most recent international guidelines workshop, should there be any change in diagnostic criteria? And the answer to that was no. We did not feel that one or another PTH assay, whether second or third generation, was really materially different in terms of making the diagnosis. And normocalcemic primary hyperparathyroidism was reaffirmed. Is there enough evidence of clinical benefit with specific medicines to recommend their use in individuals who will not have surgery? So lots of medicines have been tried. Phosphate is no longer one of the ones that should be tried. Estrogen in those postmenopausal women who are going on estrogen for symptoms of menopause anyway, if they have primary hyperparathyroidism, the expectation is that their bone calcium will drop a little bit, less than usually 0.5 milligrams per deciliter, and that their bone density will increase a little bit. Raloxifene was studied by Dr. Michaela Rubin, who's going to be talking to you next, when she was a fellow with me, and she found a small decrease in calcium levels in a very short placebo-controlled trial. Bisphosphonates are associated with an increase in bone density, and this is a study of alendronate versus placebo that our group was involved in, and you can see that lumbar spine and hip did increase, as would be expected in osteoporosis patients. Calcium and PTH were stable, did not improve or get worse. And of course, it was well tolerated, but it's not FDA approved specifically in primary hyperparathyroidism. The calcimimetics were a class of drugs that held great promise because they were the only class of drugs that actually could offer a medical parathyroidectomy, as it were, because they would act to decrease the secretion of parathyroid hormone by parathyroid cells. So that's actually the hope was they would stop lower the PTH secretion, and therefore all of the downstream effects of the hyperparathyroidism would not be seen. The only one that's currently available is cinacalcet, and it has been used and tried in primary hyperparathyroidism at variable disease severity. You can see the top line has a serum calcium at the initiation of close to 12 and the bottom line in the mid-10s. And in all cases, serum calcium can be normalized with cinacalcet and can be maintained in a normal level or normal range. On the other hand, in graph B, what you see is that parathyroid hormone levels do not normalize. And in fact, what happens is that there is a prompt decrease after the dose, but it returns close to pre-dosing levels by the next day. So the hyperparathyroidism does not resolve. And along with the lack of normalization of parathyroid hormone levels, there is virtually no change in bone density at any site. So the medical parathyroidectomy, which we were hoping would be associated with an improvement in bone density, is not. So this, similarly, there are really no data on decrease in incidence of kidney stones, and there is no suggestion, although the data are limited, that cognitive ability or quality of life improves. The SF-36 did not change. And so the drug, although safe and well tolerated, is really indicated only for patients who can't undergo parathyroidectomy and whose serum calcium is too high, because it's not going to do any of the other things that would be hoped for. So the question was whether or not any of the guidelines for surgery should be updated or altered based on some of the data that I've shown you so far today. First, the panel affirmed that anybody who had classical symptoms of primary hyperparathyroidism should be sent for surgery. That was easy. The first guideline was a serum calcium one, which the guideline had been anybody whose serum calcium is more than 1 milligram per deciliter above the upper end of normal, thus answering the question that you posed earlier. And there wasn't any data that suggested that that number be changed. It is important to note that number is picked out of the thin air. There are no data that says that 11.1 is okay and 11.3 is bad, right? So it was completely, yes?
Sometimes we'll have a patient that will be like, 11.8, but then the next check, like 2 months later, it'll be like 10, and then it'll be back to 11.8 and 10. So it'll be like.
So that's it's very usual to have variability.
Yeah.
To have a variability of 1.8 milligrams per deciliter, I would think you better check your assays. Because we actually did a study. We did 3 baseline samples on all of the people who were initiated into our study. So we had 3 samples on each of 140 patients. And there's no question that they undulate. The people who are undulating around 12 may come into the mid-11s. The people who are undulating around 10.4 may go into the high 9s or up to the high 10.8. If somebody is undulating from 10.0 to 11.8, they are either extremely dehydrated on one day and perfect on another, or there's something wrong with the assay. The other thing is that if you have a patient who is undulating into the high 10s but generally lives in the mid 11s, I would operate on them. I mean, what's the downside? There's, and the issue is that you don't know exactly how much time they're spending at the higher levels of serum calcium, and there are excellent data that show that some of the cardiovascular indices and outcomes are associated with higher serum calcium levels. So if I had a patient who spent at least part of their life well into the 11s, I wouldn't hesitate. I would send them for surgery. The next area to look at in the guidelines was the renal parameters. The prior guidelines had gotten rid of the 24-hour urine calcium level because they are inconsistent. I must admit that I was never self-confident enough to have a patient with a 24-hour urine calcium of 550 and say, oh, don't worry, maybe that's just today, and maybe tomorrow your 24-hour urine would be different. Again, it's sort of talking about what you were mentioning. If somebody has a really, really, really high 24-hour urine calcium, even part of the time, why would you not tell them that you don't have to have this and put that extra nephron at risk? So, 24-hour urine is back in both for elimination of the diagnosis of FHH and for a renal stone risk profile, and people with urinary calciums over 400 often are sent for surgery. Certainly in my clinic, they are all sent for surgery. What we added this time was renal imaging to detect occult kidney stones. Dr. Walker has recently published that about close to 20% of people have non-clinical kidney stones, that is stones in the kidneys themselves, so that they are not causing trouble, who have primary hyperparathyroidism. And if you add that to the 20% who have clinically apparent kidney stones, it suggests that about 40% of patients with primary hyperpara have stones. And the argument in favor of looking at these occult stones is that, we look for occult fractures, vertebral fractures. We look at people's bone density, which is another subclinical issue. Why not look at a subclinical renal manifestation and act on it? In the bones, just one last mention on the renal imaging. We never specified what to do. So, if someone comes into the hospital with signs of a kidney stone, they end up getting a spiral CT that costs $1 million and has a lot of radiation. We don't think that that's necessary in these patients. So what we do is either an ultrasound or just an abdominal flat plate, because you're not looking for any kind of stone, you're just looking for a calcified stone, which you would see on a flat plate, and that's very cheap and easy to do. Going to the bone guidelines, the T-score of -2.5 was reaffirmed. Come on in, we're almost done. Fragility fracture history was similarly reaffirmed as a guideline for surgery. And what was added was vertebral fractures, so that some sort of imaging, which could either be spine films or VFA, if that's available. And the final criterion, which as you can see is the only one that is actually demographic and not a feature of the disease itself, age. When the first set of guidelines was initiated, 50 was again just like the cutoff of 1 milligram per deciliter above normal. It was basically picked from thin air. The feeling was we had no idea what 34 or 35 years of this disease would do, so we just decided that anybody who was younger than 50 was too young to live with the disease for the rest of their life, but there were no data on it. And actually it turned out that here at Columbia we were not so good at following that guideline. And so the first 8 or 10 years of our natural history study, we actually didn't send people as commonly to surgery if they were just under 50, but met none of the other guidelines, all of which reflected disease severity. So we actually had a whole group of people who were young who had been followed, and what we actually found was some evidence to provide ammunition for this age cutoff, and that was that the individuals who were under the age of 50 who were followed without intervention, about 2/3 of them developed progressive disease as reflected in coming to meet a new guideline for surgery, and that you can see in the blue bar, whereas only about 22% of individuals over the age of 50 came to develop a new guideline or had evidence of progressive disease. So this actually provided evidence for the use of age as a guideline. Once again, as I mentioned before, there's nothing magic about 50. We have no idea if 48 would be better or 55 would be better. And again, in my practice, I tend to send people who are on the younger side for parathyroidectomy. So can people be monitored without surgery, and how should they be monitored? And basically these are the current guidelines. Serum calcium should be monitored annually. I actually at the beginning monitor it twice a year. 24-hour urine is done at the beginning and only repeated if a stone is suspected clinically. EGFR or creatinine clearance should be available annually, and bone density, we like to do it every year if we can. There are some countries in which that was a complete non-starter, and so we say 1 to 2 years, and some insurances won't pay, but certainly it's desirable to do it more often. And re-imaging for stones only if clinically suspected. What about patients with normocalcemic primary hyperparathyroidism? So basically the guidelines that there are sort of the same. If they progress to hypercalcemic disease, you follow the guidelines for hypercalcemic disease. If they don't progress to hypercalcemic disease, we sort of use the same guidelines. I will say that in my practice with normocalcemic primary hyperparathyroidism, I need to be pushed to send people to surgery, but certainly do that sometimes. And any of these data and surgical recommendations are completely not evidence-based, right? So there's really no data that underlies it. It was a bunch of experts in a room. I was one of them. It doesn't make it better or worse. There's just no data for this. So to conclude, primary hyperparathyroidism is clearly a disease that has evolved over time. Classical primary hyperparathyroidism is very rare in the US, but is still seen in some parts of the world, and particularly in areas where vitamin D deficiency is endemic. Asymptomatic primary hyperparathyroidism, as defined, maybe not totally asymptomatic, continues to be the most common clinical presentation, but we also see normocalcemic primary hyperpara here, and in other parts of the world it's starting to be seen more commonly as serum calcium levels are obtained more commonly as well. The guidelines for surgery were revised in 2014, and we know that surgery works. It cures the disease and helps bone density. Patients who do not meet any guidelines seem to be safe to follow for a period of time, but according to Dr. Rubin's data, maybe not forever. And that there's very, very limited data on both natural history and clinical course in patients with normocalcemic disease. The medical interventions work for individual aspects of primary hyperpara. The calcimimetics work for serum calcium. The bisphosphonates work for bone density, but there is no medical equivalent of parathyroidectomy available. And furthermore, there are still lots of questions that remain. We don't know still whether guidelines apply to normocalcemic primary hyperparathyroidism. We still don't know about fracture risk and fracture site specific risk. We don't know if FRAX works in primary hyperparathyroidism or how it should be adjusted for those who have the disease. There's much we don't know still, as I mentioned it when I talked about those sections about cardiovascular manifestations and neuropsychological manifestations, and particularly the reversal of the latter. We don't have a specific nomogram for repleting vitamin D deficiency in primary hyperparathyroid patients. We don't know whether renal impairment is reversible. The preliminary data that we have suggests that it is not, but we don't know whether it is at all, and we really don't know about, in terms of pharmacologic treatment, if an individual comes to you on a bisphosphonate and then it goes for a parathyroidectomy, should it be continued or stopped? We here tend to stop it for at least a year to allow that exuberant post-parathyroidectomy increase to happen, but we actually do not know whether that is doing patients a service or a disservice. So there remain a robust number of unanswered questions, and we would obviously welcome any of you that became interested enough to start answering them with us. And this acknowledges some of the many people who've worked on this over time. And with that, I thank you for your attention and for bearing with me. So we started 10 minutes late, so I'm sorry. Anyway, and I also have to thank Dr. Rubin, who swapped time slots with me. So. So I'm very grateful to her for all of the data she provided for this talk, as well as for many other things. All right.